Hi, my name is Joel Blumin. I'm a professor of otolaryngology at the Medical College of Wisconsin in Milwaukee, Wisconsin. I am the chief of the Division of Laryngology and Professional Voice.
Hi, I'm Dr. Seth Daley. I'm an associate professor at the University of Wisconsin-Madison. I am the chief of laryngology there and the fellowship director. We were tasked to maybe ask each other a few questions and put our heads together about common issues, problems, concerns related to spasmodic dysphonia. So Joel, when someone comes into you with a neurological voice disorder, they come in with a diagnosis of spasmodic dysphonia. What do you do first?
Well, first we listen to their voice. Once when the patient comes in to see us, we talk to them and we get a history from them. And during that history taking and listening to their story, we're listening to their voice. And when we're listening to their voice, we're listening to the quality of their voice. And spasmodic dysphonia has a certain type of sound. We call it prosody or speech quality. That we can hear, and we could hear breaks or we could hear breathiness, and we can diagnose that problem often during the initial interview.
When you say we, who's we?
So in our clinic we see patients in what we call a multidisciplinary approach. So we see patients with speech pathologists. Often there's also a nurse practitioner, some residents. We have a large group that sees the patient, and we all come to a consensus of to what's going on.
Would you say that when you were a resident, when you were in training, you would have been able to make that sort of diagnosis?
Not always. It does take a lot of training to learn about spasmodic dysphonia. Learning how to listen to voices is something that we do in the laryngology and the voice world. We spend a lot of time listening to patients and listening to what's happening.
I can say, at least from my perspective, that when I was a resident, I had very little idea for sure about what spasmodic dysphonia was, who the patients were, etc. And that really only by interacting with them and seeing more and more and more that I began to feel comfortable. But I agree with you that having a consensus is helpful. A team will always pick up different little elements of refinement of someone's voice and maybe pick up things that you wouldn't have picked up yourself.
And spasmodic dysphonia is often a disorder that's well treated medically, not so much with therapy or behavioral management techniques that the speech pathologists do. But that said, there are exceptions, and plenty of exceptions to that rule that I've seen, and there are definitely some patients who will treat with botulinum toxin therapy, but will get some benefit. The term is to unload them or to relax the way that they're voicing with voice therapy. And so it's a combination of approaches, and I wouldn't get that combination of approach if I didn't have a speech pathologist that saw them.
Mm-hmm. What do you think are the most easily confused voice disorders with spasmodic dysphonia?
Muscle tension dysphonia is the most common disorder. And muscle tension disorder, we define it by some of its response to treatment. We treat this
what kind of treatment?
With a behavioral approach with a speech pathologist, and we can often mimic it. A lot of us do this in our clinics all day long. We kind of make these tight voices, and that is a form of muscle tension dysphonia. And patients, for whatever reasons we don't really understand, they get kind of locked into these tension patterns. And usually with some relaxing type of voice therapy, patients can get into a normal voicing pattern.
What do you think about voice therapy? If someone comes in and says, I was referred here because I have some sort of voice disorder, I was told I need voice therapy, and they said it would be a 30-minute session and then I'd be cured. Does that sound right to you? Or?
No. Voice therapy, unfortunately, is a process. And sometimes when patients come in with the attitude that it's only going to work in a session or two, they get frustrated. And sometimes we see patients that have had a session of voice therapy and they say it didn't work, and all the speech pathologist told me was to kind of go And I point out to them, well, saying is a good relaxing technique, but the ultimate goal is to get you to talk. And so we need to spend the time to transition some of the exercises to ultimate voicing and speech in our day-to-day activities.
Okay. What if someone says to you, I have a sister and a mom with with something similar to what I've got? What does that trigger for you? Does that mean anything, or is that useless information? What does that mean?
Sometimes it's useful, sometimes not. Sometimes there are patterns that people learn in families, almost not related to spasmodic dysphonia, but we certainly see mothers and daughters that sometimes talk in the same way. On the other hand, there are some patients with spasmodic dysphonia that have it in their families. In fact, I have a patient I have a mother and son team who comes in for their botulinum toxin injections every visit, and they certainly have the same sort of dysphonia, which is a spasmodic dysphonia. They get different dosing on their Botox, interestingly enough, though.
Okay, so some similar, some different.
Yeah.
All right, last question. When you are making a diagnosis, what are the components that you include? You said something about history and maybe some tasks and physical exam. Could you tell me more?
So we like to listen to their voice, and then we like to tax it. We like to stress the system and listen to how they voice with certain types of weighted sentences. So things that are weighted with a lot of tightened vocal closures are things like...
You mean like vowels?
Like prolonged vowels, or we eat eels every Easter. Some patients have trouble with that. On the other hand, some patients with an abductor variety of voice problem may have trouble with sounds that are made while the voice box is relaxing, like Peter will keep at the peak. And they might say that Peter will keep at the peak. And so we do these weighted sentences to sort of tax the system and listen to what happens. And then we do a laryngoscopy. We look at the larynx. At the end of the day, we need to see what the end organ is doing. Oftentimes it's to rule out other problems. There are certainly other problems that happen in the voice box that can parallel some of the things we hear, and so we want to make sure that we don't see any of these other issues going on. And sometimes people even have secondary diagnoses. If a patient smokes or has a lot of reflux, for instance, you'll see a lot of inflammation in the larynx, and while the inflammation is not probably the source of the problem, it is certainly something that can be addressed or treated.
What questions do you have for me?
So tell me how you treat a patient now that you've diagnosed them with spasmodic dysphonia. What kind of things do you offer, and how do you tell them that they're going to spend the next year, for instance?
Okay, so that's a really good question. The treatment for this, although there are numerous options, tends to include either observation. Maybe somebody says, you know what, I'm glad to know what I have, and I don't want anything for it. I would say that that's a rarity, but certainly no treatment is an option. Voice therapy in and of itself may be helpful for education, for relaxation techniques, for relaxed breathing, but again is not going to stop the spasms and is really not treating the disease, but it can be supportive for sure. Botulinum toxin injections, which are usually performed in the office. Some people, again, will prefer the standard technique, which is small needles through the front of the neck. Some prefer a technique where you use a camera through the mouth, as well as the delivery system with the small needle into the vocal cords. And then you can even use a transnasal scope. But basically it's injection once every 3 months, every 4 months. A key expectation management point is that it's a little bit like cooking. You don't know exactly what's going to happen until you start. So although we have good starting doses to approximate what we think will be a good result, that may not be true. We might need to have more or less, or choose different muscles. And so making sure that they know that the first year or so, maybe less, is sort of an exploration, is definitely important. And then there are surgeries, or operations rather, which you're expert in, that people can also select from.
So how would you treat a patient different, for instance, if they lived at home alone, worked on the computer a lot, and had a lot of long travel distance to see you, versus somebody who perhaps didn't really need to travel very far, but they're a CEO of a corporation, really need to do a lot of public speaking all the time. And when they've had Botox in the past, they didn't really like the breathy period that they had from some of the dosing.
Yeah, so as far as expectations go, many people in the first few days will have that breathy period. They can even have to be a little bit careful not to cough and choke on liquids. If individuals are very vocally active, sort of CEO type, or teacher of 8 hours a day with third graders, or cold calling or human resources or whatever it's going to be, sometimes those individuals benefit from slightly smaller doses administered slightly more frequently. So maybe they go every 10 weeks for an injection versus every, say, 15 or 16 or whatever it's going to be. And that way they might not get quite as good, but they're not going to get quite as bad either. Mm-hmm. And so they'll have lower highs and higher lows, if you will. And so I think that tends to be a pretty good strategy. Another thing that happens also with people of a certain age group, especially here in the cold winters of Wisconsin, is people go to Arizona or Florida, or they snowbird someplace, and they'll go away for 6 months and say, you know what, I'd like to get my injection, and then I'll see you when everything thaws. So there's no law against getting being sort of off schedule, except that people will have probably a few more voice symptoms when they're not being treated.
Yeah, I find that treating with botulinum toxin is always titratable. We always are adjusting it to the patient's needs. And we can give very low doses to give them sort of minimal ups and downs, or we can give them large doses, and sometimes the ups and downs are big, but the longevity perhaps is a little bit longer, and they enjoy that.
If you're going to look online, mm-hmm. okay, if someone's online and they have Google in front of them, what do they put in? Do they put in spasmodic dysphonia? They put in what?
Well, there are a variety of websites now that are dedicated to treatment of spasmodic dysphonia. I have to give a plug for the National Spasmodic Dysphonia Association, which is dysphonia.org. They do a very good job of presenting patient scenarios mm-hmm. in a very even-tempered manner. There's a lot of stuff on the internet that for a rare disease kind of goes all over the place. And you really want to find something in the middle of the road that's going to give the patient the best information without a lot of hyperbole. And then let the patient go from there to figure out what's going on.
So probably the American Academy of Otolaryngology, mm-hmm. which is sort of a mouthful, but
yep.
I think that's entnet.org.
I think so.
Is a good one. There's ASHA,
yep.
the American Speech and Hearing Association. Those are probably good places to start. Mm-hmm. But usually another good way to do it is, I think, to include your region. So,
yeah.
if you're in Florida, put in Florida, ENT, spasmodic dysphonia, Wisconsin, Illinois, Chicago, whatever it's going to be.
And I believe the National Institutes of Health also has an information sheet on spasmodic dysphonia mm-hmm. Through the NIDCD, the National Institute of Communication and
Deafness and Communication Disorders.
Yes,
yeah.
As well as the Dystonia Coalition, which is a grant that was set up by the NIH to evaluate different dystonias. Mm-hmm. They all have information online.
How would you say that? What would you say has improved over the last 10 years, globally speaking, for patients with spasmodic dysphonia?
I think the resources are out there, and I think patients are being better informed. There's a classic problem with spasmodic dysphonia that there's a delay to diagnosis. Patients identify that they have a voice problem, and it takes them some time to find a physician or a provider that can actually treat the real problem. It's not unusual that we hear stories that patients can take years, in which time they're told that they are crazy or they have a psychiatric problem before they find the appropriate physician. It seems like that time has shrunk with the information that's out there. And patients, instead of taking years, might take months now, which is actually a significant improvement, and that's a good thing.
Do you feel like Botox is safe?
Botox is very safe. Botulinum toxin is a medicine that we use for treating a variety of disorders. We use it at very low doses, and there really are minimal side effects beyond treating the muscles that we treat.
Have you ever had a complication from Botox in the office?
No.
No, neither have I.
Yeah, probably the worst complication might be a slight bruise, but even mm-hmm. that is pretty rare. No infections, no systemic kind of issues where people worry about getting actual botulism. That just does not happen with the doses that which we use.
What would you say are people's greatest frustration with Botox injections?
As we've talked about, botulinum toxins is a titratable medicine, and so there's a lot of, the more you give, the more effect you have, and the less you give, the less effect to no effect you have. And so we as physicians are always trying to figure out what the optimal dose is for a patient, but no patient is the same as the last patient. And sometimes patients are not even the same from day to day. I certainly have patients who get a regular dose. Then recently I had somebody who had a wedding with her daughter's wedding, and she was going to talk at, and she was kind of in between doses and wanted to know how to optimize that dose. We're always adjusting, and it's good to adjust on the fly, and communication is very important. The patients need to communicate with us. We need to ask the appropriate questions, and then the patient needs to be receptive to sort of learn what we can do to adjust the dose appropriately.
Here's another question. How do you know who the right person to go to is? Like, let's say you go to a website, you're a patient, and you go to the website of your regional ENT, and it says Botox offered. What does that mean? Is that confidence inspiring? How do you figure out more?
Well, I would ask if they do treat a lot of patients with spasmodic dysphonia and voice disorders in general. Most of us that do treat patients with voice disorders hone a bit of our practice to that. And it's not just a small part of our practice, but actually a very large part of our practice.
Yeah, I guess, for me, if I were a consumer, one thing I would definitely want to look out for is that when Botox is offered, that most of the time Botox is cosmetic. And so if you're, looking on your local or regional ENT's website, and they say, we do Botox, you're going to want to probably make a call and say, are you doing Botox for cosmetic reasons, or are you doing them for spasmodic dysphonia?
And I agree, delivery of the Botox medicine into the muscles of the face is a totally different process than delivering it into the voice box. It does require a little bit different technical expertise.
There's an old expression in medicine which is that common things occur commonly. Well, the opposite is also true, that uncommon things occur uncommonly. And so, for better or for worse, spasmodic dysphonia is a very rare disorder, and given that it's a rare disorder and that it can be very challenging to diagnose, there simply aren't that many people who are invested in it, who are good at diagnosing it, and who have the skill sets to take someone sort of from goal line to goal line. And so that means that when you're looking for care, you want to feel secure, whether it's by talking to your friends, talking to other patients, looking on websites, making phone calls, whatever it is, to try to assess that sort of person that you're looking at really does a whole lot of it. Because typically if you do a whole lot of it, you're invested in it and you are going to get good at it.
And if you go to see a physician for any voice problem and your doctor sees you, says you have this, and gives you a pill and says you'll get better, but you find that you're not getting better after a couple months, it's probably time to either ask them again and see if they can reevaluate and figure out what the diagnosis is, or to find somebody who does have that expertise.